Anyway, we did a talk, so we're going to talk about BNP. This is, we did a whole talk on this last year. Anybody come to the course last year? So you remember, of course, the talk on BNP. Okay, so this is a little different talk, and I actually think that the principles that we discussed last year are the really important ones. So with your permission, I'm going to spend about 10 minutes talking about what we went over last year, and then we're going to see what this new set of papers tells us about. But it's really, I think, of a little bit less importance. So last year we said, what's the big issue that people do BNPs for, and what are the questions we have to ask? Why does anybody do a BNP? The main reason. So C is the cause of the shortness of breath, CHF. That's supposed to be what it does. So, and there's all these studies out there which says, oh, we tested it and it predicted. And so the first question you have to ask is, when you hear that, and how well does it predict, by the way, the BNP predict, yes, no, it is CHF? How good is it? According to the Great. So first of all, if you look at, so there are different ways to look at a test. You could look at it as a yes or no. Yes or no, the best cutoffs are something like 100 or 300 or 250. Every study has a different best cutoff. That by itself already tells you that it doesn't work all that good, because in one study, what worked pretty well in one study didn't work in the next study. There was a different cutoff that was good. Using those types of numbers, the best cutoff numbers, the best you can do is about 85 to 90% predictive. That means it gets it wrong 10 to 15% of the time. That's what it means. Now, there is something different, which we're going to get back to a little bit in a minute, which is what you just said. That's if you want to have one cutoff, yes, no. It does better if you use a very high cutoff. If it's very high, it's likely to be CHF. Very high likelihood. And if it's very low, it's very likely not to be CHF. Unfortunately, it isn't that often that it's very high or very low. So if you want to use one cutoff, it's about 85 to 90%. But the question you got to ask me, remember we talked before about diagnostic tests, got to be reliable, accurate. Well, there's one other thing, which is they got to compare to a gold standard. You got to know what was the gold standard that they're predicting. When it says it's really good at saying it was CHF or it wasn't, what was the gold standard they were using? So what's the gold standard for CHF? So echo. So some studies used an echo, but it actually doesn't predict very well with the echo, and neither does the echo predict very well CHF. Why? Because the echo only shows you systolic failure, which is only about half a failure. There are sort of criteria for diastolic failure, but nobody can agree what they are, and when people look at echoes, they all disagree with each other whether they have them or not. So echo is not a good gold standard. It would get you wrong 50% of the time. What else? Chest x-ray. Well, chest x-ray is one of the things that we have. We don't need a BNP if we had a chest x-ray. Chest x-ray is about 85% accurate compared to the gold standard. So it's about as good as a BNP. But we're talking about using this instead of x-ray. Why? So but anyway, what's the gold standard? The gold standard in all the studies is what the cardiologist thought. That's really it. It's astounding. All of these studies are based on a gold standard of here's what the cardiologist thought. Now, it's what the cardiologist thought, not at the ER, but at the end of the admission. Looking at all the data, here's what they thought. So, you know, I'm willing to believe that a smart cardiologist knows all the data, you know, might be pretty good at deciding whether or not it's CHF, but let's not fool ourselves that it's 100%, right? Can't be 100%. So the reason that this is supposed to be a problem, that we need a BNP, by the way, is because when we say yes, no CHF in the emergency department, we disagree with the gold standard about 15% of the time. So now we have this test, it's going to predict better. Well, first of all, it doesn't predict better. All the studies say it predicts better than an S3, it predicts better than a murmur, it predicts better than JVP, but it doesn't predict better than we do, using all the information. Compared to the cardiologist, we're about 85 to 90%. And remember, anytime you compare the ordinary working stiff to the expert, when they disagree, doesn't mean that we're always wrong. So we disagree 10, 15% of the time. Some of that time, we're probably right and they're wrong. But just be aware the gold standard isn't perfect. Even worse, there are two of the many studies which have been done about this, where they used the cardiology gold standard, but they didn't use one cardiologist, they used two. There's a lot of studies where they do it. They have a consensus. They agree, yes, no, it is congestive heart failure. That's the gold standard. But the fascinating thing is, two of the studies actually tell you how often the cardiologists disagree with each other. And how often do you think it is? 15%! The gold standard is internally inconsistent exactly as often as they disagree with us. If you just think about this, everything else, it's a house of cards. We don't have any idea what this test predicts because the gold standard is very far from gold. That's one thing you should know right from the start. The second thing is, if you're going to use it, it doesn't work very well using it as a cutoff of 142. It works pretty well if you use, if it's 1,000, they got congestive failure. If it's 200, if it's 50, they don't have congestive heart failure. When you do that, it agrees with this flawed gold standard 95, 98% of the time. Okay? So it's really good if it's very high or if it's very low. Is it? What do you have to ask before you say that? How good are you? We disagree with the cardiologist 10, 15% of the time, but we don't disagree on all the cases. If you look at, if you ask the emergency doc, are you sure it is? When we're sure it is, we agree with the cardiologist 98% of the time. When we're sure it isn't, we agree with them 98% of the time, just like the BNP. When we're unsure, we disagree with them after they've got all the results, just like the BNP. So the question is, when is the BNP going to be very high or very low? And guess what? It's in those cases where you're already sure. When you're really sure this is obviously pulmonary edema, the BNP is almost always very high. When you're sure, no, it's asthma, the BNP is low. And when you're not sure, neither is the BNP. So the percentage of the time where it actually could help you is about 5 to 10%, where you aren't sure and the test was extreme. And even with that, that's still not good enough. Because what is the question you're asking? What's the real question you're asking when you're seeing this patient who's short of breath, could be CHF, maybe isn't? What questions do you really want to know? What am I going to do, right? Does it hurt you to give them some nitrates? Almost never, right? You can say, look, I'm not sure it's CHF, but I might as well treat it. The real question is, do I have to go looking for pneumonia? Well, that's easy. We get an x-ray, right? Do I have to go looking for a PE? That's a big one, right? So, now I get the BNP. It's 0. I better look for a PE. Maybe that's why he's short of breath. On the other hand, I get the BNP and it's high. He's got congestive heart failure. Should I worry about a PE? Who gets PEs? The single biggest association with acute PE is not cancer, it isn't surgery, it isn't traveling on a jet plane, it's congestive heart failure. Just because they have congestive heart failure doesn't mean you don't have to worry about it. It might mean I'll treat the failure. If everything gets better, I won't go looking for the PE, unless there was some real risk. But you could do that without a BNP. So it's really hard for me to think of how this test is going to help me in the vast majority of my patients. If you can think of a patient where you really think the answer is the test is going to give you useful information that you're going to use it, by all means use it. I can't think of it yet. Me? Never. Never. Let me tell you. Okay. Yeah. It's perfectly okay. It's the same like getting a blood alcohol. It's interesting. No, yes. If you can think of a way in which it helps you, I haven't found that. Most of the time, if you're sure, you don't need it. You shouldn't believe it if you're sure. It's usually going to agree with you. If it doesn't, you shouldn't believe it. If you're not sure, you could get it, and it's almost always going to be non-helpful. But sometimes it might give you, it might say, yeah, I guess it is failure after all. But it still doesn't help you decide the really important questions of what do I do next? Do I have to worry about that other thing? Do I ever get it? Of course I do. Not because I work with residents. So very often they'll come back and they'll say, the BNP is, and I say, I don't want to know. But I do, I look at it and I go like, oh, well, that was really helpful. It's the same way that I look at, I see lots of CBCs for abdominal pain. And I go like, why in the world did you get that? But it's 12,000. Well, that really helps me. I understand. So you're talking about something else. Does it have a chronic? Is there a role for a baseline and then seeing the change? Unfortunately, there is no literature that says that actually predicts anything. There is a literature that says it predicts outcome, but it doesn't tell you what to do about that. So if you have very high BNPs, you probably have, chronically, you probably have worse outcomes. But it doesn't help you dealing with the patient. It doesn't say what you could do to fix that or anything like that. But in terms of, is this episode, it's up or down? No, unfortunately, it doesn't follow today or tomorrow. It tends to be over time because it's measuring stress to the ventricle, which doesn't change 1 minute to the next. I don't. If you can think of a way, tell me, because I can't think of a way. Sure.
If I got the baseline, I know what part of it is their COPD, then maybe.
Yeah, it's not nearly good enough to say it changed this much in this time, therefore this episode isn't or is. There's nobody claiming that. I mean, people may claim that, but there's no data, no literature claiming that. And then it turns out like all these things, like a CRP is really a great test. The reason it's such a great test is because it's great for everything. It's specific for everything. So, yes, that's what this, so we've now got, that's the segue into this year's talk. And this year's talk is about, well, wait a second, it goes up in everything. So here's the list of things it goes up in. We don't have to go through the individual articles. Here's what it goes up in. It goes up in, if you're a woman, it's different. If you're older, it goes up. It goes up in sepsis, even if you don't have heart failure. It goes up if you're anemic. It goes up if you have renal failure. If you have acute airway disease that's not cardiac. If you have low body mass. If you have cardiomegaly, atrial fibrillation, pulmonary embolism, and critical illness. So that helps me distinguish. If it's none of those, why am I even seeing this patient? Then there's this chapter actually has a series of papers that you could use to teach a course about terrible papers. I mean, it's just astonishing, some of these. And I don't have the time to go over, I don't think we should go over each of them individually. But one of the things that they do is they often confuse, it's associated with something with, it helps you make a decision. So associated with means, we look at the patients who had disease and people who didn't have the disease, and the test is more likely to be high, let's say, in the people who had the disease. Well, that's never a relevant question. I don't care whether it's more likely. I care, does it help me in this patient decide yes or no? So if it's high in 70% of the people with the disease and 69% without the disease, it's associated with the disease. Am I going to use it to decide who has disease or who doesn't? So here's a nice paper. Number 2, they did multiple biomarkers to predict outcome. And they found that while none of the biomarkers were actually any good, they found a statistically significant increase if you used a combination score involving various biomarkers, including the BNP. And they give you a p-value of 0. With a million zeros, and then there's a little dirty little secret there, which is that the R equals 0.03. So how many of you know what that means? They trust you don't know it. They don't know it. That's why they can write these stupid papers. So what it means is that 2% of the variance is explained by this complicated combination of markers. You're 2% more likely if you have these 5 markers in this pattern than if you don't. Which means that it cannot possibly have any value. 2% more likely. You want to make a decision based on that? There's 29% chance of being, he needs this treatment, this life-threatening saving treatment, 29% chance if he has this, and only 27% if he doesn't. Oh, well then, if he doesn't, I'll send him home. 2 of the papers have this, where they actually tell you, they obviously don't understand their own stuff, where the amount of the variance based on it, and it's so trivial as to have no possibility of having any clinical meaning. There are lots of problems with a lot of these papers, but nevertheless, they basically say, although their conclusions are often what a great test it is, they basically say this goes up in all sorts of acute disease. It is affected by all sorts of acute disease. So even, and you know, personally, I think even in the ideal person who doesn't have renal failure, who doesn't have chronic heart failure, who doesn't have an arrhythmia, isn't critically ill, doesn't have sepsis, and you're not worried about a PE, it still very unlikely to help you for the reasons we all talked about. But remember that all those people who are complicated, the patients you take care of, tend to be excluded from all the studies which say how good it is. So I personally don't think this, again, if you have a patient, you think you're going to use the information in a reasonable way, that's perfectly reasonable. It's absolutely, that's the same true for lots of tests. There is actually a way to use a D-dimer rationally. Not very often, but you can. There is a certain patient where if you use it rationally, it can actually help you. It won't usually help you. Very few patients fit in, but occasionally it will help you. There is one case where a SED rate is useful. You're looking for temporal arteritis. But we get, you know, even a CBC is useful if you're looking for leukemia. But most of the tests that we use, most of the simple tests we use, don't really help us, and we're just smart enough to ignore their results 95% of the time, which is what you do, right? But I personally think that we should do better than that. We should say, I don't want to use the test in somebody where I'm going to ignore the results anyway. So if it's a surgeon, just make up the right number because they don't read. You know, it's 18,000. Too high, 18,000. Oh, I meant 14,000. You know, we have to live in the real world. We deal with consultants. There is no simple answer for that. But I do think that part of our job is not to act like we're, you know, the intern who's just there carrying the bags for them. And so when they say, well, what's the BNP? You say, well, of course the BNP wouldn't be useful in this case. You know that, of course, because I'm sure you've read the literature. Like, oh. You know, I remember one of my favorite cases ever was the case where we had, well, in the 80s, there were these papers which showed that if you had a clavicle fracture and you did the standard figure of 8, it actually didn't heal better than if you did a sling, but it was associated with all sorts of complications, brachial plexus, neuropraxias. It was much worse to put them in a figure 8 than a sling. So we started not putting them in a figure 8. We started putting them in a sling. Casey was probably there at the time. And I got a call from a friend of mine who was an orthopedic faculty, and he said, I hate to tell you this, but one of your residents, you know, he's really screwed it up. He didn't even put the guy in a figure of 8. And I said, ooh, it wasn't my resident, it was me, you know. And it was like, that's because it doesn't work, you know. It's like, so over a period of a year, we had this series of interactions where we would get complaints about us idiots in the ER who didn't even know to put on a figure of 8. And each time we would say, well, actually, you know, it's sort of interesting. You might want to read the articles in the orthopedic literature showing that it's no good. And then over a period of a few months, it came from a complaint, you idiots, to, yes, we know all that, but we think it's better. In our experience, it's better. And then I knew we had succeeded when some point 6-9 months later, some orthopedist came down to the ER and attempted to teach us about how you don't need to do a figure of 8. I think that's part of our job. Okay, I think we're done.